Well, hello everyone, and welcome to Internal Medicine Residency News Conference. Very happy today to have Dr. Nick Van Wagoner here. Nick was a chief medical resident when I was a resident in the program, and he was a big leader then, and he's been a leader at UAB ever since. He is a bit of an underachiever, getting both an MD and did his training at UAB for med school residency and his ID fellowship. He's currently the Associate Dean for Students and leads the Office of Medical Student Success. He attends on general medicine wards on Tinsley Harrison, where he's attending right now, does some ID research and lots of other things to help UAB. So he's going to fill us in on what we need to know about sexually transmitted infections. So Nick.
All right, well, thanks, Ryan, for the opportunity to be here today with you remotely and to talk a little bit about sexually transmitted infections. And so what I'm going to focus on today, as you can see by the title, is Climbing Rates Concerning Trends and Opportunities for Impact. Recognize that this was pre-COVID, and I will be very curious to see what social distancing does for the state of STIs in the future. But let's see if it'll go forward. No, it's not. Let me try it this way. There we go. So just disclosures so that you are aware. I do research on herpes simplex virus therapeutic vaccines, and I also do receive funding through the CDC for the STD Prevention Training Center. And so really, I have two main objectives today that I hope to cover. And one is to talk about and describe the current landscape of STIs in the United States. And I will focus some on Alabama as well. I put congenital syphilis here because we are seeing an uptick in the number of cases nationally. And so I think it's important for us to cover some of that information and make you aware of that. And then really toward the end, what I'll do is identify a few practical ways to address the STI epidemic in clinical care. So the STD surveillance data for each year comes out in October. And so the 2018 STD surveillance information was available to us October of 2019. And what it showed is that STIs have increased every year for the last 5 years. If we look specifically at the different STIs, you can see that chlamydia cases were up 19%, gonorrhea cases were up 63%, and this is up from the previous year, over the last 5 years. Primary and secondary syphilis cases were up 71%, and if we look at congenital syphilis cases, those were up 185%. So looking at that, we know that STIs continue to be a concern. They continue to cause substantial morbidity for our patients and are something that we as healthcare providers need to be aware of and we need to address and take care of. So what I want to do for just a moment is talk about the three reported sexually transmitted infections. That's chlamydia, gonorrhea, and syphilis. And this is where I will focus most of the presentation. I'll talk a little bit about the epidemiology as well as the symptoms and the diseases that each cause. The reason that I'm talking about these separately is because I know that we often lump STIs all together, but I think that it's worth remembering that they actually are separate epidemics that affect different groups. And being aware of that helps us to decide who we need to screen when we need to screen. So when we look at the clinical syndromes associated with C. trachomatis, I've got it divided here by men and women. And we can see that the most common causes for men is a urethritis, but it can cause a conjunctivitis and it can also cause a proctitis. Those are the simple, so to speak, diseases that they cause. They can have complications, though, and these include epididymitis as well as reactive arthritis. And ultimately, if untreated and the disease is severe, they can lead to infertility. In women, conjunctivitis, urethritis, and proctitis are still possible, but the most common presentation when symptomatic is cervicitis. In women, the complications include endometritis, salpingitis, and perihepatitis. Women also do get reactive arthritis, but at a much lower level than men, at least associated with chlamydia. We worry about infertility as well as ectopic pregnancy as really the most severe consequences of these infections. When we look at chlamydia and what has happened with its numbers over the last several years, and particularly in the last year, what we've seen is an increase among both males and females in all regions of the United States and among all racial ethnic groups. We see the highest rates among adolescents and young adults, which is really 14 to around 24 or 25. And while there are more reported cases in women, and this is typically observed or seen as a disease of young women, which dictates also the types of screening we do, we have seen an increase in the rate among men, and you can see almost an increase of almost 40%. If you look at where we see it, and again, this is reiterating what I just said, the highest proportion of cases are in those individuals 14 to 24. And among age folks 14 to 24, we see the most cases among racial and ethnic minorities. STIs in general are an important example of a health disparity and one that we need to address in more detail. This is just giving you an idea of what we're observing as far as chlamydia cases. And I've already said this, but it does show you that the number of cases continue to climb, and the slope of that line, both in men and women, seems to be relatively steady. So to Alabama in particular, not bad. We're not number 1 or number 2. We rank number 15th in the United States as far as cases of chlamydia. And if you look at the southeastern United States, what you will see is that really it's the hardest hit area when it comes to chlamydia and also to other STIs. I put up one more slide related to chlamydia, and really the point of going through this or looking at this is that even within states, when we think about a state, we have to think about specific areas where we see higher rates. And so if you look at Alabama, the darker the blue in this particular case, the more infections or the higher the rate. What you will observe is that the infections that we are seeing are really, you're right. Look at Alaska. It's got a lot, doesn't it? Sorry, I just saw that in the chat. But you are correct. But the point I was making is that what we observe is that there are certain areas that are more affected than others. And while we often think of large cities as being affected, in Alabama and in other states in the southeastern United States, rural areas are hit particularly hard by STIs. All right. Now, although we're not going to go into more in-depth than the first-line therapy, I do want to remind you that the first-line therapy for chlamydia is either azithromycin 1 gram times 1 or doxycycline 100 milligrams BID for 7 days. And the regimens that I'm giving you are for typical infections. All right, so that's a little bit about chlamydia. Let's talk more about gonorrhea for just a second. The syndromes that it causes, again, conjunctivitis, urethritis. In this case, we've got both men and women together, cervicitis, proctitis. What you will also see here, which was not seen in the previous case, is that it can cause a pharyngitis. For men, complications include prostatitis and epididymitis. For women, again, endometritis, salpingitis, and perihepatitis. Remember, with gonorrhea, though, you can develop bacteremia, which can lead to a disseminated infection and diseases associated with that dissemination that are listed here. If we look at what is happening with gonorrhea and really of public health concerns, is that we are also seeing an increase in both male and females in all regions of the United States and among all racial groups. In this case, and in contrast to what we see chlamydia, we actually see more cases in men, right? Another important feature of gonorrhea is that more than half of all infections are estimated to be resistant to at least one antibiotic that has been used, may not be current first-line therapy, but has been used at some point in the past to treat this infection. All that being said, I will say that all circulating strains are susceptible to ceftriaxone. with the caveat that there was, I believe, a strain that was recently reported to the CDC that was resistant to ceftriaxone. The good news is it was not resistant to azithromycin. But all of this to say that this is an organism that responds pretty effectively to everything that we throw at it and has been able to develop resistance to our therapies. Again, another example of a health disparity. We see differing rates based upon race ethnicity with non-white populations, for the most part, not in all cases, but having a higher risk of gonorrhea. As I mentioned before, the rates are highest among men, and this is the reason why. What you can see here is that the group with the highest numbers and also with the greatest slope is men who have sex with men. It's hard to tell because of this, the extreme change among men who have sex with men, but there is a slight increase among women as well as men who have sex with women in the rate of gonorrhea. So why is this the case? Well, this is a study. This was a smaller study, but it's been replicated in multiple different ways and shows that extragenital infection with gonorrhea, and as I'm showing here as well, with chlamydia, is quite common. And this has it broken down by HIV status, and you can see the rates there. But both for gonorrhea, we see pretty high rates of rectal as well as pharyngeal infection. For chlamydia, you can see the rates of rectal infection, and we really don't see a lot, and we actually don't quite know what to do with it at this point, pharyngeal CT. We don't see that quite as often. But this accounts for a large number of the cases that we see of gonorrhea. And a point that I want to make is that if you look first at the bottom half of this particular image at urethral infections and you look at gonorrhea, what you will see is that 90% of urethral infections are symptomatic, and they're going to get a person to the clinic. Only 10% aren't. But if you look at the top and look at rectal infections, around 84% of rectal infections are asymptomatic, which means that the vast majority of people with rectal infections will not know that they have it. And so this means that if we were to only screen the genitals or the urethra, specifically among men who have sex with men, in this particular study, and again, this has been reproduced with varying numbers, but still large numbers, in this particular study, if they had only screened the urethra, they would have missed 95% of gonorrheal infections among men who have sex with men. And so it is important to consider screening all, not just considering, but screening all sites among people who have had exposures and are at risk. And so for those of you eating, you're welcome. I put this up here just to remind you of the way people in the field of STIs think about screening. That is the triple dip. For gonorrhea, we should do pharyngeal screening with nucleic acid amplification. We should screen urine. We can do that for both gonorrhea and chlamydia. And we should do rectal screening as well for both gonorrhea and chlamydia. It is not currently recommended that chlamydia screening be performed in the oropharynx. However, as many of you know, if you have done these tests, they are linked, which means that gonorrhea and chlamydia testing occurs together. If you were to get a positive chlamydia test, you would want to go ahead and treat for chlamydia as well. All right, so back to gonorrhea. We're a little higher achievers in the case of gonorrhea than we are chlamydia. We rank 4th in the US as far as number of cases. And again, we are in good company with others in the southeastern United States where we see a high prevalence of all STIs. As I mentioned briefly as well, there is resistance to most antibiotics that have been used to treat gonorrhea. And I will say worldwide, all antibiotics. And if there's not frank resistance, there is increasing minimum inhibitory concentrations. And so the CDC's recommendation to try and address this is to use treatment with 2 agents. Okay, so in order to treat gonorrhea, we treat with both ceftriaxone, 250 milligrams intramuscular, plus azithromycin, 1 gram PO. Okay, so but either treatment alone is not enough and is not recommended. Dual treatment is recommended for the treatment of gonorrhea. So y'all, I don't have my, right now, my chat open because I can't get it to not open over the middle of the screen. So if there are questions, I'll come to them at the end, okay? All right, so what does the future of gonorrhea treatment look like? Certainly we're looking for new agents, and a lot of this work has been done here at UAB in the South. Solithromycin is a fluorochetalide, which actually went all the way to phase 3 trials. Unfortunately, it doesn't look like it works as well as our current treatments. 2 other agents are currently being evaluated. You can see both of them there. They have shown good activity against gonorrhea as well as potentially other sexually transmitted infections. And so hopefully there is promise for new agents becoming available to treat gonorrhea in the future. So let's turn our attention now to syphilis. When we think of the natural history of syphilis, we are all familiar with it being in different stages, or primary, secondary, and tertiary syphilis. But I think that it's important to also understand that syphilis doesn't necessarily have to go through each of these stages, okay? And we may not see clearly each of these stages in our patients, okay? So people are exposed, they then develop primary disease, and infection and disease in the same location. And I'll go through that in just a second. They can then move on after dissemination of the organism to secondary syphilis, which has a number of different manifestations, after which that will, the immune system will take care of the disease manifestations, but doesn't cure the infection. And it goes into what we call latency. Now, latency, it can stay there. About 33% of people, if untreated, will progress to tertiary syphilis and its different manifestations. I also want to point out, though, that latency, that secondary syphilis can recur. It doesn't necessarily have to be a one-time thing, okay? And so just to keep that in mind as you are seeing patients. So some pictures. Primary syphilis. Typically, it presents as a chancre at the site of infection. It's painless. It is an ulcer with heaped up borders. You may observe regional lymphadenopathy. And as I said, it occurs at the site of primary inoculation, and it typically heals within 2 to 6 weeks. I am showing you different locations of chancres to demonstrate that they can be at the site of exposure and not always on the genitalia. Now, typically lesions will heal before the manifestations of secondary syphilis, but that's not always the case. And a person can have a chancre and manifestations of secondary syphilis at the same time. We see a rash not infrequently. It can be widespread. It's typically symmetric. You can see the colors. It may just be macular or flat. It may be papular or palpable. Typically, it doesn't itch. It can be indurated, and it can also have a superficial scale. You may also notice fever and generalized lymphadenopathy with this, because again, remember, this is because of dissemination of the spirochete. Here are some other examples of secondary syphilis that are classic, but not always present symptoms. So you may see the classic palmar rash or the plantar rash. You may see the nickel and dime lesions, which I have seen twice in my life, but it's, you know, when you see it, it's syphilis. But don't forget, it can also cause alopecia or hair loss. Other manifestations are listed here. And I think it's important to remember that meningitis can be a symptom of secondary syphilis. And we are seeing more cases of iritis and anterior uveitis, or eye and ear involvement, okay? Hepatitis, one of the best cases, and the first case I ever saw of hepatitis was here at the VA. With a guy who had both skin manifestations and super elevated AST and ALT. It can also cause a periostitis as well as nephropathy or a nephrotic syndrome. You can see mucus patches or condyloma lata, as I've shown you pictures here, and recognize that these are highly infectious lesions if you do see them. Coming back for a moment to neurosyphilis, though, one of the things to consider is if you have a patient who has syphilis, secondary syphilis, to ask about these symptoms, or to do a physical examination to assess for them. You can see cranial nerve dysfunction. As I mentioned previously, auditory abnormalities as well as ophthalmic abnormalities. Meningitis, we do see strokes, acute or chronic altered mental status, and you may see loss of vibration sense. So important aspects to consider if you have a patient who has evidence of syphilis, or you have a patient who has risk of syphilis and they present with these manifestations, it should certainly be on your differential. All right, so what have we seen with syphilis? Well, we've seen an increase among males and females, again, just like all other STIs in all racial and ethnic groups. We have seen the majority of cases for the last several years among men who have sex with men, in fact, 53% of the cases, and many of those are HIV infected, okay? But I do want to point out that there is also a rapidly expanding heterosexual epidemic, okay? Over the last 5 years, there's been a substantial increase in the number of cases of syphilis among women. This breaks it down just to show you sort of the differences over time. And what I will call your attention to is women. If you look at the slope of the line, there has been an increase in the slope over the last year in particular in the number of cases. Alabama ranks 17th in the United States for the number of cases. We are surrounded by lots of states with higher numbers than we do, so we have to be vigilant around continuing to work on keeping our rates low. Looking a little bit closer at women and also at congenital syphilis, what I want to point out from this particular graph is you can see through the line that is the number of cases of primary and secondary syphilis among women, okay? And it has been increasing. And not surprisingly, what we see if you look now at the blue columns is an increased number of cases of congenital syphilis. So taking a moment, I know that we don't often think about pregnancy and what we do, but I think that there is relevance. And so I want to make a couple of points from this particular slide. First of all, if you look over at the side with chlamydia and gonorrhea, these are typically lower genital tract infections. And so exposures can come through the birth canal. There are cases of chorioamnionitis and endometritis as well. But you can see the manifestations there, okay? Certainly, syphilis does cause lower tract infection and can lead to those particular consequences. But also remember, it's a bloodstream infection, and that infection occurs at the placenta. And if we look at that and we look at the placenta a little bit more closely, what we can see is where mixing and where infection occurs, really at the fetal portion of the placenta, where there is mixing of blood from the maternal arteries that then can infect in this space and get to the infant. So if we come back to the outcomes of infection, what we know is that it leads to a lot of inflammation. And so the inflammatory process can lead to preterm birth and as well as intrauterine growth restriction. We do see congenital infection as well as stillbirth. Now, the time that we see these different symptoms depends upon the time that a woman is infected or has the infection during her pregnancy. And in order to understand this, we really had to go back, I don't know, 60, 70 years to gather this data, okay, or to be able to look at this data. But what you're looking at is pregnancy outcomes in women with early syphilis versus those diagnosed with syphilis late in their pregnancy, okay? And what you will see is that the likelihood of a non-syphilitic infant, okay, or an infant without any consequences from that infection when the woman was infected early was 20%. In other words, 80% of infants had sequelae of that infection. Now, with late syphilis, certainly the numbers are lower as far as sequelae of the infection, but still 23% of infants had some sequelae from that infection. And so what that means is that this is something that we need to think about and we need to address in pregnancy. This is a study looking at various places. This is from 2016, and it looked at mothers of reported congenital syphilis cases and where there were opportunities to intervene and where those opportunities were missed. Well, certainly prenatal care accounted for the greatest majority of missed cases, and that makes sense. Certainly, that is not only an issue at the clinical level, but that is an issue at the much larger national level of how to provide care for all people. However, for people who are in care, screening, the lack of screening and the inability to treat in time also accounted for some cases. Inadequate treatment after screening accounted for many, and also rescreening. So what this means is that a woman had a negative initial screening test, but later was infected and was not diagnosed until delivery. And although we may not be able to intervene in each individual place because we may not be able to control the ability of every patient to get health care, certainly for people in care, for example, looking at rescreening, there is an opportunity to reduce the numbers. So we'll come back to that in a moment, but which factors are putting US women at risk for acquiring syphilis? Well, one of the most important that we are learning and observing is that this is related to persons who inject drugs. And so what we have seen is a steep increase and more cases of syphilis among women who inject drugs than men who have sex with women or men who have sex with men. That's one risk factor. But the other risk factor is also having sex with someone who is an injection drug user. This also puts a woman at risk. And so we have to think about this in the context of our screening. Now, as I think that we all are aware, if a woman were to come into clinic pregnant and were to reveal that she was using injection drugs, there is a chance, or even a really good chance, that there would be consequences for her and also for her, potentially for her ability to keep the child. Even if there aren't consequences in reality, which of course there are, women in this position may fear sharing that information. And so it may actually be a better tactic that instead of saying, as we do in this state, that we only screen in the first trimester and we screening is only required in the third trimester for women at risk, that there may be an opportunity if we just screened all women in the third trimester to at least reduce some of the cases of congenital syphilis that we are observing. And I want to take a moment to thank Jody Dion Odom, who generously shared some of the slides related to congenital syphilis. So let's talk about treatment for just a moment. Current treatment for syphilis depends upon the stage, okay? For primary syphilis, secondary syphilis, or early latent syphilis. What does that mean? That means that we believe that the person has been infected for less than 1 year, okay? How do we make that determination? Well, they had a test for syphilis in the past year that was either that was negative and or non-reactive, depending upon the testing modality that is being used. In that particular case, we give benzathine penicillin 2.4 million units intramuscularly as a single dose. For latent syphilis, in other words, people who have been infected for greater than 1 year, or we don't really know how long that they've been infected. In this particular case, we give them 7.2 million units total, which is 3 doses of 2.4 million units each week times 3 weeks. In pregnancy, we want to treat with penicillin, and that still remains the answer on exams, and it also remains the answer in real life. And that is that we want to ensure that they do get penicillin. Neurosyphilis, you can see the treatment there. I look it up because I can't remember it until I have a case, because I see them so far and few between. And for congenital syphilis, the reason I refer to the STD guidelines is because they are a little bit more complicated. And so this would also be a case where I think I would bring in an expert if you were treating a case of congenital syphilis. That probably really only applies to those of you who are med peds, since I hope to never treat a child because I have no qualifications to treat children. All right, so for a minute then, let's talk a little bit about social distancing and STIs. When we think about the factors that influence infection, we think about 3 main things. We think about transmissibility, okay, of a particular infection. This is the probability of infection given contact between infected and uninfected persons, okay? Now, that's not going to change in most cases. Yes, condom use may change that, but in general, transmissibility for an organism is going to be relatively constant. Duration of infectiousness. Certainly, duration of infectiousness is the second important factor. And finally, what is the rate of contact between susceptible and infected individuals? Now, if people are truly social distancing, we might expect the rate of contact between susceptible and infected individuals to decrease. However, if people are not able to get access to care, we might figure that the duration of infectiousness is increasing. So in all honesty, I don't know what's going to happen with STIs and social distancing, and I will be interested in looking. But I will bring up historically a couple of points. So what you're looking at is syphilis rates over time. And I put the factors influencing infection up here to help us think a little bit further about this. If we go back to 1941, with syphilis, an important thing happened around that time, and that was the development of penicillin. And so what we saw there was a drastic decline in the number of cases of syphilis with treatment. In other words, we decreased the duration of infectiousness, and so there were fewer infections. Now, around 1985, we did see an uptick of cases of syphilis, and that was related in part to cocaine use, and is linked to the crack cocaine epidemic. Around that time, something else happened, and that was that HIV was discovered and understood as far as its sexual transmission. And so what we saw is a decline in the number of cases of syphilis after that point. And this is likely because of potentially transmissibility decreased because of the use of condoms in that particular case. And now, as we move on toward 2018, what you are seeing is an increase again in the number of cases of syphilis. And this probably is related in part to the reduction in condom use around because of the decreased risk of acquiring HIV, whether that's because of viral control in people who are infected, because we understand that if their viral loads are undetectable, they really can't transmit the virus to someone else. It likely also represents in part the the introduction of pre-exposure prophylaxis and the reduction and its protection against HIV. Again, two factors that are probably playing a role there. Now, as you can see, that number is going up. And what I would say is that even if social distancing does decrease the number of cases of STIs that we see, I suspect that over time we will see an increase or return to sort of the whatever normal is levels of STIs. All right. So this is the much shorter part of the discussion, and really will be done in about 5 minutes or so. But I do want to identify some practical ways to address the STI epidemic in clinical care. Okay. And so the first is to make a point and to advocate for continued screening in all of our clinics. It might surprise you, it may not surprise you to understand that STD clinics diagnose the vast minority of STIs in the United States. And what you're looking at with these different presentations or representations is first gonorrhea. And if you look at that gray area in that particular graph, that is the number of, or the percentage of cases diagnosed in STD clinics, which again is the vast minority. You can see, looking at primary and secondary syphilis as well, although in a different type of graph form, that the majority of cases are not diagnosed in STD clinics. So what that means is that people that we all need to be cognizant of the need for testing and screening. And so I'll bring you back to ICM for a second and remind you of the important parts of the sexual history. Now, I think that one of the things that we learn over time is not just the questions that we need to ask, but also how we need to ask them. And what I mean by that is creating an environment where people feel that they can trust us, that they understand why we're asking them these questions, and that we are asking, and to build on that we're asking in order to support and help their overall health. But we do need to understand information around their partners. We do need to ask follow-up questions, and we need to not make assumptions based upon spousal relationships. It is important for us to ask questions about partners. We also need to understand practices. We need to understand practices so we know where to screen in order to help keep our patients healthy and also to reduce spread. We need to understand what folks are doing to protect them from STIs, and also to understand if they have a history of STIs. Why is that relevant? That may help us because we do know that if a person has had an STI in the past, they are more likely to get an STI again in the future. We also want to understand pregnancy. And, this is taken from the 5 Ps from the CDC, and typically it says pregnancy prevention. However, I think that takes in a pretty big assumption that people don't want to get pregnant. And I think that there are many cases where people may wish to get pregnant. And so thinking through that and how that relates to their risk of STIs, I think is also relevant. Another key factor that I think is super helpful and is letting our patients do the work. I'll show you the screening guidelines in just a moment and talk through those in more detail. But it is very, very rare, and I have a sexual health clinic that I actually will collect specimens on a patient. I have them go to the restroom, and if they need to collect a vaginal swab, a rectal swab, if they need to give me a urine specimen, I have them do it. I still do collect oropharyngeal swabs. However, there are places in the nation where they allow patients to do that. It's super easy. If they're not having any symptoms, we also understand that patients do a much better job of specimen collection than physicians and other healthcare providers do, and the results are better. So anytime I can, I allow the patient to do this. And so if we're talking about efficiency and somebody's coming in for an STI screening, literally the conversation may take 5 or 10 minutes. If they're asymptomatic, that's it, and they're done. All right, so let's talk a little bit about screening. I don't expect you to remember this, and I don't. I typically just use an app that I'll show you in just a second because just it helps me to make sure I'm accurate and that I'm up to date. But the group that we think about most as far as chlamydial screening is women. It goes back to where we see the infection the most and also where we see the most severe sequelae of these infections. And so the current guidance and recommendations are that women, all sexually active women under the age of 25 years of age should be screened. And this is screened annually. Sexually active women over the age of 25 and older should be screened if at increased risk, and we should retest approximately 3 months after treatment. So I want to make it clear, this is not a test of cure, okay? This is, we know that people have high risks of getting infected because reinfected by a partner. And so we want to make sure that they have not been reinfected. So that's the rationale for that. You can see the recommendation for pregnant women. You can see for men as well as men who have sex with men. I'll point out men who have sex with men because they also have a more detailed screening recommendations, and that is that at least annually for sexually active MSM at site of contact. So that includes the urethra and rectum, regardless of condom use, okay? And that we should consider screening every 3 to 6 months if an individual is at increased risk of acquiring infection. If we go on to gonorrhea, what you are going to see is that the screening recommendations aren't much different, okay? Women under 25, over 25 if they have increased risk, and retest at 3 months. Your only difference you're going to see among men who have sex with men is that we should be screening at least annually. In this particular case, we add the pharynx, and again, regardless of condom use, and that we should screen every 3 to 6 months if at increased risk. Now, what you are seeing is that there's an absence of screening, of broad screening recommendations for men, okay? Now, the recommendations actually say, depending upon the prevalence in a certain area, that we should go ahead and screen. And I will share with you that the practice at the health department here, because we do have a higher prevalence of gonorrhea, as I mentioned, we're 4th in the nation, state by state, is to go ahead and screen for gonorrhea as well. Syphilis screening, you can see the recommendation for syphilis screening. You will notice that this is the CDC's guidelines. Each state has its own recommendation. And so the state of Alabama is that we screen at the first prenatal visit, and we screen those at risk during the 3rd trimester. You can see again for men who have sex with men and also persons living with HIV. In this particular case, you do see that the recommendations from 2015 do not suggest that we need to routinely screen women for syphilis. Now, the guidelines are being updated and should be released sometime this year, and we will see with the uptick that we're observing among women if this will change. So how do I keep all of this straight in my mind? Because we all have a million other things to do, and it can be challenging to get everything in and remember everything. And so what I use is this app. It's free. It's through the CDC, and basically it's the STD treatment guidelines on your phone. It's very, very easy to access. But for example, if you had a question about chlamydia, you can click on that. It will then give you information around diagnostic considerations. It will also give you treatment and follow-up guidelines. So a very, very useful tool for assessing and treating STIs among your patients. The last thing I will say is occasionally a question will come up, or I should say not infrequently, questions will come up, and you may have something that you're not sure how to answer. What do I do about this patient with X, Y, or Z? I want to let you know that there is a resource. If you just go to www.nnptc.org, this is a CDC-driven group that you are able to upload a question, and this is for healthcare providers only. If you have a question, that is then sent to an expert in the area. and that expert will contact you by the modality that you choose within the time period that you choose, and will work through the case with you and help you come up with a solution or a plan for the case. So with that, I'm going to go ahead and stop. We've talked, I hope, some about the two main objectives, and then I want to say thanks. I want to, first of all, for being a part of this particular presentation and allowing me to present this information. But I've also want to say thank you for another reason, and that is that I've been able to work alongside many of you for many years, and also alongside some of you over the last few weeks on inpatient services, and I get to continue that on another team starting tomorrow. And I want to say how much I admire and appreciate the work that everyone is doing. No, it may not be on the front lines of taking care of patients with COVID, but what we do, I think, is pretty courageous on a day-to-day basis. And so thank you for your fine examples, for working hard and doing your job at sacrifice to yourself and your families. And so thanks. Anyway, I'm going to go ahead and end there. I'm going to stop sharing my screen for a second and see if there are any questions from anyone.
Hey, do you want to look in the chat? I think there were just a couple of things that came up, and if you're able to access it, I'll let you read it. Otherwise, I can read some questions off.
So I think I've got, let's see. So you had I'm going through this. So Kramer, you had an 89-year-old ask you if he could get sex through COVID?
Yeah, that was yesterday. I told him, and I'll let you see what you think of my answer. I told him as long as he maintained a 6-foot distance at all time, that he would be safe.
Okay, good for that.
But I think it just goes to, we shouldn't make any assumptions, right? About who's having sex and who's not having sex and who they're having sex with.
No, I think you're right. And it's a great point. We have seen outbreaks of STIs in nursing homes. We have seen all sorts of interesting things. And so you're right. Also, thank you for clarifying. You are correct that with hepatitis, you do see a very high ALK phos. You are correct. So one question is, at what point would you perform an LP to test for neurosyphilis? Only with neurologic symptoms. So there are two pieces to that question. So yes, only with neurologic symptoms when someone is coming to you with the following caveat. If you have treated someone for syphilis, okay, and you are following their RPR, and this is not something we talked about in this particular presentation, but what we expect is a fourfold reduction in their RPR, which means that they have responded clinically to the treatment. If you have a patient whose RPR remains high after treatment, that would be another case where I would consider doing an LP on the patient. Okay, so that would be the other caveat. But yes, if they have symptoms, I would go ahead and do it. So is any guidelines around screening for syphilis in reproductive age women before conception? This would be an opportunity for us in GIM to really impact congenital syphilis. So it's a great question. There is no guideline in the sense of a woman should be screened for syphilis for this. However, because, and again, I understand that that women are at lower risk in general of screening. However, if you ask me, yes, I screen for STIs. If a woman is considering conception, my recommendation is, hey, why don't we go ahead and screen for STIs as you're planning for this? And, you know, most cases, the chances of you being infected are low, but the consequences are high. Now, the question is around billing and who will pay for that and how that will work, because it's not necessarily a guideline. But remember that if for some reason it becomes challenging from a financial point in the clinic, the the health department is available and will do it for a cost of $5. I wish I could give you more and say absolutely yes, we need to do this, because I wish we could. Okay, with regards to treatment for secondary syphilis versus prolonged latent syphilis, you mentioned earlier that sometimes secondary syphilis can recur even after a latent syphilis. If we see a patient with secondary syphilis, how do we know this wasn't reactivation and that they have had latent syphilis for greater than a year? How do we know the patient doesn't need 3 doses? Great question. And so this is where I would have a conversation with the patient. The majority of cases where you see secondary syphilis occurring after primary infection are going to be early. I didn't clarify this, but most cases of recurrence are also going to be early. Okay, so if they have a recurrence of secondary syphilis, it's going to be early in their course. Okay, so what I'm saying is that the overall way I would approach this patient is, if they have secondary syphilis, I would make the assumption that they have been infected for less than a year, and I would treat them as secondary syphilis and not be too concerned about whether it is whether it was a period of latency. I think that that is going to miss a couple of people for sure, but because the majority of cases are going to be, or excuse me, the number of cases of secondary syphilis, even with recurrence, are going to be in that first year. You're going to be covered by doing the 2.4 million units. And if you came up against that on boards or a test question related to that, the answer is, if you see secondary syphilis, treat it with 2.4 million units IM of benzathine penicillin. Okay. So have EpiDocs or ID docs studied rise in the use of online dating apps and a rise in STIs nationwide? So the answer to that is yes, and there has been a huge increase. And when you think about contact tracing, it's really hard when people only know a screen name or don't know the name of their partners. So we have seen a very large increase in the number, we have seen an increase in the number. And there have been strategies, and even some of those, some sites, Tinder, Grindr, other sites, dating apps have actually, in some cases, allowed public announcements or screening information on them. Others haven't been quite so interested in that because they feel like it will affect their memberships. But it's something we're working on to try to do, or trying to address that. But it is a really, it provides or creates a big challenge for sure. All right. So question, if a patient comes to my clinic asking for STI screening, generally speaking, should I order GC pharyngeal, GCCT urine, and GCCT rectal, RPR, FTA, HIV, wet mount versus NAT for trick? Very good questions. And I'm sorry, now that I'm thinking back about this lecture, I should have put that in here. So I'm sorry about that specifically. So that is correct. Now, it depends upon sexual activity and sexual behavior, okay? So TJ, for men who have sex with men, I would get the GC pharyngeal NAT, the GCCT urine, and the GCCT rectal, okay? If I have a man who has sex with women, I would get urine, GC, and CT only. The reason that, and the rationale and why that works with, or is supported by the guidelines, is because we see a very, very low prevalence of extragenital infections among men who have sex with women, okay? So it just doesn't make sense. For a woman, the way that I do this is based upon history and risk factors. So if I have a woman who comes in who reports only vaginal sex, then of course I would only screen GCCT urine, okay? If they have other risk factors, then I would add a pharyngeal and a rectal, okay? But that would be based on my clinical decision-making based upon history. The guidelines say for women, okay, if you look strictly at the guidelines, they're just gonna say GC-CT from a vaginal swab or urine, okay? RPR, FTA. Again, guidelines tell us that we should screen men, and specifically men who have sex with men. We should screen women and men who have sex with women who have risk factors. Everyone should be screened for HIV. As far as a wet mount or what we do for trick, there are labs, and in fact, the labs that are done at our health department, and I believe that is available through UAB, you can get GCCT and trick all on one swab, okay? So in that particular case, the only reason I would do a wet mount is if a woman is symptomatic and I'm checking for bacterial vaginosis, and I would be checking for trick at the same time. What I'll do is I'll put together, or I'll put together something that I can send you that has that information, and I'll include it in my slide set. So thank you for that. All right.
Thank you very much. Oh, one more. Do you check for trichomonas in asymptomatic people from Dr. Snyder?
So I do check for trick in asymptomatic women, but I check for trick because it is a vaginal swab and collected with the other specimens. I don't necessarily do a wet prep. But I do try to check for all. And based upon the data that we see, and I'm trying to channel Christina Musney in our division right this second, we do see a pretty high preponderance of trichomoniasis in older women. So not in the 14 to 25 age group, but women over the age of 25. And so I do typically screen them if I'm screening according to the guidelines or if they're symptomatic. Okay.
Thank you very much, Dr. Van Wagner, for the wonderful lecture and then the really just kind words as well. Thank you for being a great part of our family and brightening our day.
With STIs. You're welcome.
There you go. All right. Bye, everyone.
See you later. Have a good day.